My name is Katherine Winterboer, and I'm a vascular registered sonographer. And I'm going to talk to you about superficial vein disease, symptoms, assessment, and treatment. Despite significant advancements in treatment options, superficial venous disease remains one of the most prevalent underdiagnosed vascular disorders today. It's estimated over 30 million Americans suffer from symptomatic venous disease, yet fewer than 2 million actually seek treatment. To put this in perspective, venous disease is 5 times as prevalent as peripheral artery disease and 2.5 times as prevalent as coronary artery disease. The symptoms develop slowly over years. Early symptoms can be vague. People kind of brush these symptoms off and dismiss them due to growing older or more overwhelming health problems. Superficial venous insufficiency is caused when the valves or the walls of the veins are not working properly and begin to leak. This allows the blood to collect in the calves, which causes them to swell. Over time, the increased pressure can cause the symptoms of this condition. And the symptoms vary from person to person. You may have absolutely no visible vein disease, but you have tons of symptoms, or you may have ulcers after a short period of time. Some of the risk factors are family history, multiple pregnancies, sitting or standing for long periods of time. We see a lot of truck drivers, nurses, Amazon workers, advanced age, obesity, smoking, and a history of deep venous thrombosis and superficial venous thrombosis. Some of the symptoms include swelling of the legs and feet, heaviness. Patients describe this as feeling like they are walking through mud, or they have some sort of blocks on their feet. Coldness to the toes and feet. This is something that I've been hearing from patients recently. I had a guy tell me the other day that his feet, the day of procedure, that his feet were no longer cold. So that's just something kind of new that I've been hearing from patients recently. So if they tell you they have cold feet, it could be an underlying venous issue. Hair loss, restless legs, pain aggravated by standing or walking, cramping at rest, skin changes, and trouble with balance and knee pain. Also had a lady tell me recently she was able to kind of ditch her walker and had a much better balance, and her knee pain kind of went away. As soon as the day of treatment, that night she felt better. Assessment of venous insufficiency using the SEEP score. The SEEP classification is used to classify the severity of chronic venous disorders. This is what our practice uses, the sonographers and the providers. There's a score ranging from 0 to 6, 0 no visible venous disease, all the way to active venous ulcers. This is SEEP score 0. She probably had some ankle swelling at Disney and decided she needed a venous workup. We're happy to scan these patients. They may have some underlying vein disease, but mostly move them along. Reticular veins, these patients generally do have some underlying feeder varicosities. These C2, these symptoms, these are large ruby varicosities, and these patients are really starting to have pretty significant vein disease symptoms. Those itch, they burn, they ache, and they're visually, disturbing, but the patients really have a lot of hard times with these. Edema, pigmentation, C4 and A and C4B. These patients are on their way to having an ulcer. Healed venous ulcers and active venous wounds. I called one of my fellow sonographers. He did a presentation, and he had a pretty profound little statement that I wrote down that I wasn't able to add in. He gave me this morning. So patients with C2 to C4 have equality life scores of patients that with myocardial infarct and stroke. So these patients are truly symptomatic from C2 to C4. They have some pretty significant symptoms. And then patients with C5 and C6, their quality of life scores measure around that of heart failure and obstructive pulmonary artery disease. I threw this slide in here. I like to, this is how I visualize the anatomy, rivers and creeks. It's how I explain it to our patients, and they generally understand me. In red, we have a river. That's the small saphenous vein behind the knee. As you can see, it leaks, the valves are no longer functioning, and the way that the body offloads that pressure is it creates a creek or a tributary. And I try to sometimes explain to the patients that these take a few treatments to get through, primarily because we have to treat their underlying vein disease before we can start addressing some of the stuff seen under the skin. So this particular patient could require 2, potentially 3 treatments if foam sclerotherapy doesn't work. On the varicosities, we have to move to more of a stab phlebectomy. So these are some of our treatment options that we offer at the Vascular Institute: sclerotherapy, endothermal ablation, chemical adhesive, and stab phlebectomy. Superficial venous procedures are safe and effective in closing the diseased vein by rerouting blood to nearby healthier veins and providing symptomatic relief, ultimately offering a significant improvement in quality of life. Radiofrequency ablation's been kind of our first line of treatment lately. It's good for SEEP scores 2 through 6. It's a non-surgical, minimally invasive procedure. It's highly effective in treating the great saphenous vein above the knee. Occasionally, we can use that to treat the small saphenous vein and the anterior saphenous veins, depending on the vessel diameter and length. Patients really start to see an improvement with symptoms and wound healing. Within a week, a few weeks, we start to see these wounds slowly getting smaller. There is a risk of thermal nerve injury, so we tend to stay above the knee for that reason. There are quite a few needle sticks along the course of the vein. We use tumescence to insulate, so that's probably the least, comfortable part for the patient. It is covered by most insurance companies, and the downtime is very minimal. And endovenous laser treatment is still an option in our toolbox. We've just sort of moved more to radiofrequency, but we still use laser treatment therapy as well. VenaSeal, this is a medical adhesive. It's a procedure that delivers a small amount of specially formulated medical adhesive to seal off the diseased vein. This is a non-thermal treatment. There is no risk of thermal injury, nerve injury, less pain and bruising, limited needle sticks. Some of the adverse reactions can be inflammation and phlebitis, generally treated with a dose steroid pack, and it clears that up. However, we do have some difficulty with insurance coverage for this particular treatment. It is very good for some patients that don't ambulate as well, or are obese patients where other treatment options have failed. So this is kind of our biggest gun that we have. So once we've tried a lot of things, we'll try this very last thing, and if it doesn't work, then move on to weight loss or other deep stenting, stuff like that. Chemical ablation, Varithena, and ultrasound-guided foam sclerotherapy. I'm going to talk a little about Varithena. We don't really use a lot of ultrasound-guided foam, but it's similar in nature. The treatment works by injecting a chemical irritant into the vein, causing the lining of the blood vessel to spasm and collapse down. This is really great for treating the great and small saphenous veins below the knee, because there is no risk of thermal nerve injury. It's highly effective in treating the large varicosities. This is similar to starting an IV, and can sometimes need multiple treatments. That's one of the down things about that, but some of the side effects can include pain, swelling, and skin discoloration. These are typically mild. And one of the other things that patients really don't love about Varithena, although it's very effective, is the 20 to 30 millimeter mercury compression post-procedure for about 2 weeks. We do have some problems with insurance, maybe 1 or 2 companies, but we generally don't have a lot of problems getting Varithena approved for patients. Cosmetic sclerotherapy, this is done generally at the end of their treatment plan. We have several providers that are very talented in cleaning up the cosmetic stuff. This comes as an out-of-pocket cost to the patient. It's generally not covered by insurance, and it can sometimes take multiple treatments. And that's just a little picture of getting cleaned up there. Stab phlebectomy is not the first line of treatment for varicose veins. It's usually performed on large ropey veins that likely will not respond to chemical foam. If the veins are too big, we know chemical treatment will either not work or require too many sessions, so stab would be ideal. Thank you.
get the next PowerPoint loaded. Thanks for your attention again. Hopefully you enjoyed the case that we did. We're going to shift gears a little bit in talking about deep venous disease and iliac venous compression and chronic venous insufficiency. So the classic term for this is May-Thurner syndrome, which many of you may have heard. It's pretty common in the Western societies, and they've done cadaver studies and CT studies and seen it in upwards of a third of people. So 1/3 of you in this room may have some form of iliac venous compression. Now the question is whether or not it's symptomatic or something that we need to treat. And so when we start at Vascular Institute, what we do for people who come in with lower extremity swelling, especially patients with chronic skin changes, ulcer formations, things like that, we'll do a comprehensive venous workup. So what Katherine just talked about, superficial venous insufficiency, we'll look at that extensively, but we'll also put ultrasound probes on the abdomen and look at the iliac system and the inferior vena cava. And for a long time, that was outside the realm of ultrasonographers, that was outside the treatment realm for vascular surgeons. We didn't look that high, we didn't think that high. But there's been a mind shift change in the last 10 to 15 years where we've become much more aggressive. It used to be we would treat the superficial venous system, and even when I was in training and even after that, you'd treat the superficial venous system and the patient would say, I still have swelling afterwards. You say, well, you're kind of out of luck. I don't have anything to offer you. Now we do. So now we're much more aggressive with this. Again, the incidence and prevalence is not entirely known, but obviously venous disease is incredibly prevalent throughout the population. It's the #1 cardiovascular disease of all cardiovascular diseases that exist. And so what we're talking about with iliac venous compression is the appropriate term is a non-thrombotic iliac vein lesion. And this can happen in both sides. It can happen in both males and females. I tell patients that it happens in females, and classically females who've been pregnant, and classically males who look like females who've been pregnant. But we can also see it in patients who are thin and healthy and have not had the biscuit poisoning, so to say, as well. So oftentimes I tell patients it's just bad luck that you had it. My cousin is a cross-country runner, and she's about as thin as possible, and she has iliac venous compression that turned out to be symptomatic. And so classically, May-Thurner syndrome is a crossing of the right common iliac artery over the left common iliac vein causing compression. That's the classic definition. But we actually see it on both sides, like I was saying. It was first described in 1957 by Dr. May and Dr. Thurner. They got really creative with names. And what it leads to is significant trauma within the vein itself, causing webbing and scarring. And if you remember your biology and your pathophysiology, Virchow's triad causes stenosis, causes stasis, and thus can cause thrombosis. How do these patients present? Well, like I said, we look for it in patients who present with significant swelling, edema, cramping, fatigue, but also pelvic congestion syndrome. Pelvic congestion syndrome, it is the main source of problem for a tremendous number of patients with pelvic congestion syndrome. Patients with neuropathy, restless leg syndrome, we look for it in those, and patients who present with DVT for no reason whatsoever. In almost all of our DVT patients will now look for it. Whereas in the past, we never actually looked, again, higher than the groin fold or the femoral region. And the reason it causes pelvic congestion syndrome is just that. It causes congestion. Things get stopped up. Remember, vascular surgeons are just plumbers. We're pretty simple people. But it inhibits drainage of the pelvis, causing the congestion, pain, heavy periods, painful menses, painful intercourse, things like that. Oftentimes, we'll get referrals for patients who have varicosities on their vulvar areas or in their pelvis that are seen by gynecologists in their workup. So, and that's the first sign and symptom that they'll have some form of pelvic congestion syndrome. And these iliac stenosis lesions can cause development of collaterals. So because one side is stopped up, they'll actually get swelling in both sides, and they may get swelling in the right side only, because essentially the right side has to take up some of the blood flow from the drainage of the left side. So you can see this is a left common iliac lesion, a left common femoral lesion here, and has cross pelvis collaterals going over to the right side with significant swelling in this leg on the left side. And Katherine just alluded to venous insufficiency and valvular obstruction. Essentially, the pressure up top can cause reflux down below, valvular disruption down below, and lead to significant swelling. And again, the stasis can lead to clot formation and subsequently deep venous thrombosis. So how do we diagnose this? Well, history, physical. You have to have a high index of suspicion, and I think that's really, really important. For the longest time, we didn't think about this. But now with duplex ultrasonography, we can do things and look at the common femoral region, and sometimes if you look at the common femoral region with ultrasound, it can be a guide to look higher and suggest the presence of reflux at the common femoral region can suggest a stenosis higher. And then we'll actually put ultrasounds on the abdomen and look at the diameters of the vein. CT angiography and MRA are used sometimes, but those are much more invasive and use a fair amount of radiation. You can see in this picture here, the left common iliac vein is crossing under the right common iliac artery, and that's essentially it by definition. And it's being pinned by the lumbar process. And so, as you can see in this, the normal venous diameters are somewhere around 12, 14, 16 millimeters in diameter. This lady on the left, it drops all the way down to 3 millimeters. And on the right, she has some element of compression as well, down to 6 millimeters. And I don't know how much you can see this, but this is where we're actually on the ultrasound measuring the vein diameters. So, and that's our first clue to that the patient may have some significant disease. Katherine, I think, already alluded to some of the CEAP classification, but in asymptomatic patients who we find this in, we don't typically offer them an operation unless we think they're of higher risk for developing some form of clot. We do watch them and counsel them on looking for future symptoms. Mild symptoms, CEAP 1 through 3. With the absence of thrombus, we'll treat them conservatively. Compression stockings, may do superficial ablations on them and things like that, but won't necessarily be that aggressive. But for more severe patients with severe swelling, pain, not treated by superficial ablation or ulcer formation or something like that, if they do have ulcer formation, severe skin changes, that's when we'll be much more aggressive with them. So in the last 10 years, we've kind of had a revolution in venous treatment. We have stents that are specifically designed for the venous system. Classically, we were using large stents that were actually designed for the tracheobronchial tree. And we've moved on. These stents have to have a high amount of radial force and have to be durable for the rest of the patient's life. And so the radial force props open that vein and fights that artery from stomping on it routinely for the rest of their life. The two main ones on the market are ones made by Medtronic and another one made by BD. And they're safe. We put them in our office right across the street. The procedure takes 25, 30 minutes, something like that. Very low rate of complications. I think this rate of minor complications is actually probably even overblown. Our own internal studies suggest that our rate of complications is under 3%. So what we do is we actually access the femoral vein and run a catheter up, and we run a catheter inside the vein. That's called intravascular ultrasound. We saw it in the live case presentation. And as you can see, the catheter is almost occlusive in the vein. We call it the squish of the iliac vein going up underneath the artery. Can you play that video? So this is the IVUS going in, and as you can see, the catheter essentially becomes occlusive, and then it opens up again. And then we'll put in the stent and play that video. Here, it'll play just now. And the stent props open that vein against the artery. Pretty straightforward. This is an example of the cross-pelvis collaterals that you can develop. One thing we do see is patients with pelvic congestion syndrome or significant iliac issues who present to us who have this iliac compression, and in upwards of 75% of the patients, we can treat their iliac venous compression, their symptoms will almost completely resolve. The other thing we see is a lot of young patients coming to us with these sort of issues. And the question is, can I get pregnant afterwards? Yes, they can. I counsel them pretty extensively before I would put a stent into a patient of childbearing age, but it has been shown to be safe in limited studies of patients who've received stents and then went on to be pregnant without developing thrombos. This was a 23-year-old who had severe iliac venous compression. You see the collaterals crossing over the pelvis. We went in with IVUS, showed a 90% lesion in that iliac vein. You can see the catheter going up. It's nearly occlusive, and that's it after it was reconstructed with a stent. The amazing thing is in a situation like this, all those collaterals that you saw in the previous image are gone. Same patient. Pretty amazing. This was a patient who I talked to about several times. This was an active duty gentleman who was a special forces operator, multiple recurrent DVTs, had a pulmonary embolism as well. Nobody ever looked higher. Nobody ever actually looked to see, but he had on his CAT scan, if you can look on the right side of the patient's right side and the left side, he had a severe narrowing of his left iliac vein, or of his right external iliac vein. So we did a venogram on him, and sure enough, there was that stenosis. We propped him open with a stent, kept him on blood thinners for another 6 months, and now he's deploying again, where he was non-deployable for a while because he was on chronic blood thinners. His favorite thing in the world, these special forces guys are strange. Their favorite thing in the world to do is go off to places where nobody speaks your language and be in the desert and whatnot. Treatment efficacy on this is exceedingly good. So patients get a great result from it. And the long-term primary patency is very good as well. Symptom relief, complete and partial relief is upwards of 75% over the course of 5 years. Oftentimes we'll keep these patients on systemic or dual antiplatelet therapy, or we'll do novel oral anticoagulants for 6 months or up to 1 year. If the patients have a history of DVT, then oftentimes we'll keep them on systemic anticoagulation for longer. And we also monitor their stents for the rest of their lives after we treat it. But it really is life-changing. After you put one of these in patients, it's amazing how satisfied they are and how much better they are, especially the patients who've been, with ulcers, who we can get their ulcers to heal, who have severe pelvic congestion syndrome, who've had heavy menses and things like that for life. It's really life-changing. So thanks for your attention.
Hello, I'm Monica, and I am a nurse practitioner for Vascular Institute. I work specifically at the hospital and do all the rounding at all the hospitals. My topic today is DVTs and PE. Let's see. I have no disclosures. The objectives are to define VTE, which is venous thromboembolism, and the two different types. Determine risk factors and symptoms of the two types of VTE. The diagnostics that we use for both PE and DVT, and the treatment modalities, and we'll look at a couple of case studies. So VTE is a venous thromboembolism. It refers to a blood clot that starts in a vein, usually in the lower abdomen or the lower extremities. It is the third leading vascular diagnosis after heart and stroke. Venous thromboembolism affects between 300,000 and 600,000 Americans each year. And as we said, there are two different types, the DVT and PE. DVT definition is a blood clot that forms in the deep veins, usually in the lower extremities, but it can occur elsewhere in the body. The risk factors for DVT is, the large one is immobility due to age, surgery, travel by car, plane, or medical conditions. Obesity, And age, as we move less, we gain weight, we have comorbids that increase the developing blood clots. Cancer predisposes us to forming blood clots and pregnancy with the increased blood volume. Contraceptives and hormone replacement therapy increases the risk of blood clots. Injuries or trauma such as falls or MBA. Surgery and general anesthesia predisposes patients to blood clots, and blood disorders and genetics such as polycythemia, factor V lead-in antithrombo, antiphospholipid syndrome, and the prothrombin gene mutation. Having a prior DVT increases the risk of having another one in the future, and we see this quite a bit, having peripheral IV sites and catheters, ports for dialysis and things like that at the hospital. Also, anatomic variations such as May-Thurner syndrome, which is what Dr. Harris has talked about, increases DVT risk. Symptoms of DVT, the biggest one is the lower extremity swelling. It's usually unilateral. Pain to the affected extremity, redness and warmth, tender to palpation. Infrequently, loss of pulses, sensation or motor movement of the affected extremity due to extreme swelling. This would fall under the two categories of phlegmasia, which is usually pretty rare. There are two types of phlegmasia. The first one is phlegmasia alba dolens, which translates to painful white inflammation. It's caused by DVT in the iliofemoral vein, causing pitting edema and pale legs secondary to arterial occlusion from the swelling. It's also called milk leg or white leg. And the second phlegmasia is cerebellar dolens, which translates to painful blue inflammation. There is no ischemia, but severe venous obstruction and swelling that the arterial pulse may disappear and venous gangrene may ensue. The diagnostics for DVT, duplex ultrasound is the gold standard for diagnosing DVTs. It has 95% sensitivity and 95% specificity. Ultrasound uses sound waves to look at flow of blood in the veins. It detects blockages or blood clots in the deep veins. D-dimer is a blood test that measures proteins that the body makes to break down blood clots. An elevated D-dimer may suggest a blood clot. It is useful, but it's not sensitive nor specific due to false positives. CT or MRI is usually not done to diagnose DVT due to the risk of increased radiation exposure and contrast if the CTA is done. If the iliac veins or IVC is unable to be visualized on ultrasound and there is a suspicion of higher DVT in the area of those areas, CT, MRI may be helpful to delineate the proximal extent of the DVT and the patency of the IVC. Venogram, contrast is injected into the venous system to determine the lack of blood flow to the blood clot. It is not usually done because it's not without risk due to invasive nature and uses contrast. Treatment for DVT is heparin drip. Heparin works by preventing thrombin from producing fibrin by inactivating antithrombin 3. Thrombin stimulates the fibrin, which is what makes platelets stick together and make the clots. Oral anticoagulation remains the cornerstone of treatment. It's usually Xarelto or Eliquis, but we've also used Pradaxa, Brilinta, and Epiant for cardiac patients. These are called direct oral anticoagulants, or DOACs for short, and work by preventing thrombin from acting on fibrinogen to produce fibrin. If patients are unresponsive to Xarelto or Eliquis, we can use Coumadin or Levinox injections. Levinox is low molecular weight heparin. It is approved for pregnancy. Coumadin prevents creation of the thrombin by inhibiting vitamin K-dependent clotting factors 2, 7, 9, and 10. We also use Coumadin for those who are unable to afford DOACs and for those who have genetic predisposition for blood clots such as antiphospholipid syndrome. It is harder to get Coumadin in the INR. It is interactive with a lot of medicines and foods, and so we don't use that very much. Venogram with percutaneous thrombectomy is recommended for those who have occlusive thrombus in the iliofemoral or femoral to popliteal DVT and are symptomatic with extensive swelling and pain. Lysis catheter is used to drip thrombolytic meds directly at the blood clot to help break them down. ECOS is an ultrasound vibration used along with the lysis cath to penetrate the clot better. Elevation and compression is recommended to reduce the swelling, which in turn helps the pain. Compression hose and wraps are encouraged during the day, and elevation of lower extremities when sitting, laying in the evenings. IVC filter is generally not recommended unless there is a direct contraindication for any kind of blood thinners, such as recent stroke, surgery, trauma, or GI bleed. If one is placed, then it is usually removed later. Can you put the picture up? One of my pictures did not load, but this is the case study. Number one, this patient was an 80-year-old female who presented to an outside hospital with complaints of left lower extremity swelling. She had a recent fall and fractured a toe. She had an ultrasound at the outside hospital, which showed a DVT when she was placed on Eliquis, but there was some confusion as to what the dose was that she was recommended to take. She returned a few days later with complaints of increased swelling, pain, and discoloration. She was placed on a heparin drip and transferred to Chattanooga Hospital. Repeat ultrasound showed occlusive DVT of the left common iliac artery, external iliac, and common femoral. The thrombus protruded into the IVC at the bifurcation. The IVC was noted to be tortuous. She denied prior DVT history, denied recent travel by air or car, denied family history of clotting disorders. She denied chest pain, and the CTA of her chest was negative for a PE, but it did note a 12-millimeter paratracheal lymphadenopathy. She was noted to have significant pain, swelling, and discoloration of her left lower extremity on exam, but intact sensation and motor movement with palpable pulses. She was taken to the OR for a venogram and percutaneous thrombectomy. Hematology was consulted and recommended outpatient workup for the paratracheal lymphadenopathy, and they also recommended switching to Bradaxis since there was confusion with the Eliquis dosing. So they didn't actually call it Eliquis failure, but they recommended another anticoagulant anyway. This was another patient that we saw. This is an elderly patient with left lower extremity swelling for the past month. She fell and fractured her left femoral neck. The patient became increasingly confused. Her white cell count was 23. Her lactic acid was 3.4. Her left leg was severely swollen, discolored, and painful, but insensate without movement. Ultrasound of the leg noted both arterial and venous DVT. Venous duplex showed occlusion of the left superficial and popliteal arteries. There was a DVT of all the visualized deep and superficial veins. The patient was taken for a CT of the chest, which noted scattered pulmonary emboli, but no central pulmonary embolus or right heart strain. Echo showed decreased ejection fraction. CTA also showed most of the stomach was in her chest cavity with organoaxial rotation. The patient had arrhythmia due to hypokalemia, and her clinical condition was too critical for surgical intervention. We recommended palliative and hospice, and she expired 48 hours after admission. This is definitely phlegmasia. So switching to PE, definition of PE is pulmonary embolism is an obstruction in the pulmonary artery due to a clot, tumor, air, or fat. It occurs when thrombus has been formed in the systemic veins and it breaks off and is carried by the venous return to the heart and ultimately to the lungs. A saddle embolus is a clot in the main pulmonary artery that transverses the right and left pulmonary arteries. Saddle PE is associated with a higher clot burden and increased incidence of right heart failure. Epidemiology is approximately 900,000 hospital admits per year with 200,000 deaths per year in the U.S. There are 1 to 2 PE cases per 1,000 people, and the mortality of untreated PE is 30%. $10 billion a year is spent on PE management, significant burden on the U.S. economy. And 75% of patients presenting with PE have a DVT, and that's why we always order a lower extremity ultrasound on a patient with a diagnosis of PE. 50% of patients with proximal DVTs also have a PE. Risks for pulmonary embolism are very similar to DVT risk. Genetic and family history of hypercoagulable disorders, recent surgery, immobility, cancer, pregnancy, obesity, Chronic medical conditions such as COPD, heart failure, hypertension, stroke, inflammatory bowel disease, and as always, smoking is a significant risk factor. Symptoms of PE include shortness of breath is the classic with some chest pain. They can have a cough, feel a racing heart, syncope or pre-syncope. Those are common. In the hospital, we typically note tachycardia, hypoxia, and hypotension on the monitors. Patient may even have hemoptysis when coughing. The diagnostics that we use for PE, the initial workup may include a chest x-ray, but more commonly, CTA of the chest is done and is considered the gold standard. CTA shows a burden of clot, where the clots are, and can determine if there is right heart strain involvement. If patients have chronic kidney disease or is unable to have a CTA, then a BQ scan can be done. BQ scan compares pulmonary perfusion with pulmonary ventilation. An echocardiogram is obtained to determine ejection fraction and to measure for right heart strain. D-dimer, EKG, troponin, and BNP are ordered as well. As mentioned earlier, every patient diagnosed with PE has a lower extremity ultrasound done to determine DVT status. Stratification for PE treatment, we determine if there is right heart strain, and you can see on the little cartoon over there, the right ventricle and the left ventricle. If the right ventricle is 0.9 or greater, then you have right heart strain. The higher the number, and the worse the heart strain is. On the left side, what's my left side? The little cartoon right there says, for minor or low risk, there's no right heart strain noted on echo or CTA. The heart rate and blood pressure are stable, and the oxygen saturation is stable with no elevation in biomarkers such as troponin and BNP. We recommend oral anticoagulation with usually Eliquis or Xarelto. The medium risk, also known as submassive PE and is a gray area, includes right heart strain noted on echo, some positive biomarkers with elevation in troponin, BNP, and some EKG changes. However, if the hemodynamics, like blood pressure, heart rate, and O2 sat are stable, then we recommend oral anticoagulation. This is a gray area due to clot burden and patient symptomology, such as shortness of breath and pain. We may decide that thrombectomy is needed anyway for symptom relief and better long-term outcomes. High risk or massive PE is included when there is a right heart strain, positive biomarkers, EKG changes, hemodynamics are unstable requiring pressors and possible respiratory support. Those patients are immediately taken for pulmonary thrombectomy. Treatment is usually with oral anticoagulation, like I said, Xarelto or Eliquis, thrombolytics, if we have to do a lysis catheter such as alteplase, TPA, streptokinase, urokinase, pro-urokinase. Alteplase is the recommended thrombolytic for PE given over 1 to 2 hours. It can also be given during pulmonary thrombectomy, drip directly at the clot. Absolute contraindications for thrombolysis include prior intracranial hemorrhage, intracranial neoplasm, ischemic stroke within the last 3 months, a GI bleed, or any recent head injury. Pulmonary thrombectomy is you essentially go in with special catheters and suck out the clot. Catheter fragmentation is a catheter with an enclosed impeller driven by an air turbine. The rapid spinning of the impeller creates a vortex that agitates the thrombus and draws it up to the tip to be sucked out. Patients that are drastically unstable and crashing, i.e. hypotension needing pressors or inotropes, respiratory failure needing mechanical ventilation, arrhythmias, these patients can be put on ECMO for additional support during thrombectomy. They are decannulated prior to leaving the OR. Typically, immediately when thrombectomy is finished, there is a drastic improvement in heart rate, blood pressure, O2 sat, and patient's shortness of breath. This is a PE case study that we did not too long ago at the hospital. This is a middle-aged patient that presented to the ER with complaints of chest pain and lower extremity swelling. They were being worked up for cardiac issues. They did not have a CT in the ER. There was no history of prior DVT or family history of hypercoagulable issues, and no recent travel, no reports of cancer. But the patient decompensated on the floor and developed acute respiratory distress with hypoxia and hypotension. He went for a stat CTA of the chest, which showed a massive PE and significant right heart strain. He was transferred to the ICU on 3 pressors and placed on BiPAP. And when I saw the patient, they were crashing. His pressures were in the 60s and 70s. The patient was taken emergently to the OR by Dr. Lassar for pulmonary thrombectomy, and Dr. Wiesen cannulated the patient and placed him on ECMO. These pictures show before and after the thrombectomy, so you can see before and then you can see after there's better flow. And there's another picture. And the last picture shows that the clot was removed and where they were located. As noted on the top of the page, at the very top, you can see that the patient's heart rate was 132 and OT-sat was 78, and he was on BiPAP. Post-thrombectomy in the OR, heart rate was 99 and OT-sat was 100% on nasal cannula. The patient was weaned off his pressors prior to going to the ICU, and the patient stayed in the ICU 1.5 days before being transferred to the floor. Those are my references.
All right, good afternoon. I am Frank Cuozzo from Portsmouth Naval Hospital, and I am delighted to be here. I'm going to talk to you about pulmonary embolus. I have no disclosures. So acute pulmonary embolus is a partial or complete occlusion of the pulmonary arteries, and it's caused most of the time by lower extremity DVT. The symptoms of a PE can range from nothing, totally asymptomatic, to complete cardiopulmonary collapse and cardiac arrest. And that depends on patient factors and clot factors. In terms of the pathophysiology, after an occlusion, you get a release of potent pulmonary artery vasoconstrictors, you increase pulmonary vascular resistance, you increase your right ventricular afterload, which can lead to hypokinesis and dilation of the right ventricle, which leads to acute renal failure. The clot can organize into permanent fibrotic deposits, leading to chronic pulmonary hypertension, and this can lead to chronic right heart failure. Now, when it comes to diagnosing PE, you need to have a high index of suspicion, and there are tools that can help us with this. The simplified Wells score is one of these tools. If the sum of the various clinical signs is greater than 4, then PE is likely. In terms of the workup, a negative D dimer can rule out a venous thrombotic event very well. On imaging, classically, we obtain a chest x-ray to rule out any other underlying chest pathology. The kind of the classic imaging that we get for PE is a CTA that there you can see as a saddle embolus. So these are all for diagnosis. Now, in terms of prognosis and risk assessment, troponin and BNP can be very, very important. An echocardiogram and a venous duplex can also help you stage the patient in terms of their risk factors. Now, risk categories of a PE are defined in the context of an anticipated 30-day mortality rate. The categories are low, intermediate, which we also call submassive, high, which we also call massive. And they're based on the fact that the mortality risk increases with significantly increasing evidence of right heart dysfunction. Evidence of right ventricular dysfunction includes, as I said before, these elevated cardiac biomarkers. On CTA, we are looking at a size ratio between the right ventricle and the left ventricle greater than 0.9. On echocardiogram, we also are looking at a size ratio between the right and left ventricle, and the ratio is greater than 1, shows that there is significant right heart strain and right heart dysfunction. And as you can see, there are a lot of other objective findings on CTA and echo that also point towards this right heart dysfunction. Now, mortality in PE has not changed very much in 20 years, unfortunately. All-cause mortality at 30 days was around 12% in the International Cooperative PE Registry in 1999. And then in the PERT registry, it's still about the same. And you can see when you divide it into the two different risk categories, they're significantly different. Now, there may be other powerful predictors of mortality other than just right heart dysfunction. And it's interesting to note in the center chart that there is an increased frequency of coexisting DVT in the higher risk PEs. So it begs the question, in these patients, should we be prioritizing their DVT treatments as well? Another potential complicating factor is the amount of clot that's left over in the pulmonary arteries after treatment that causes a continued pulmonary artery obstruction, and this is called the residual pulmonary vascular obstruction. From the studies that we see here, at least 20 to 50% of PE patients do have this RPVO after treatment, and that's either with anticoagulation or some type of lysis intervention. And the residual obstruction seems to be associated with increased adverse events that include mortality, recurrent venous thrombotic events, heart failure, and a chronic pulmonary hypertension. And additionally, the more residual obstruction you have, apparently the worse off you're going to be. There are other variables that have been previously shown to be associated with increased mortality with PE, and they have been combined to form this index, the Pulmonary Embolus Severity Index. And these predictors include age, male sex, comorbid illnesses, and clinical factors. So for example, if you tally up and you get a score of 86, that will put you in class 3, which gives you a 6.5% chance of 30-day mortality. Now, what are the treatment goals in PE? Number 1, prevent mortality. Number 2, prevent late PE sequelae, improve your functional capacity, and most importantly, the benefits of these strategies, the interventional strategies, should outweigh their risks. The idea of standardizing treatment for medical conditions has been gaining momentum in the United States and abroad, and this is true for pulmonary embolus as well. So in 2012, Dr. Rosenfeld at Mass General Hospital created the first pulmonary embolism response team. This is a multidisciplinary team that is able to rapidly evaluate and treat patients according to standardized care algorithms that are data-driven. Now, this figure represents potential components of a PERT team, but it's certainly not limited to these teams alone. The PERT Consortium was born in 2015 when 40-plus PERT teams came together in Boston and started it. It is a phenomenal resource to help guide PE care and research with essentially the goal of improving survival rates. They have a clinical practice and protocols committee that seeks to standardize PE clinical care through these clinical algorithms. Here is a PERT Consortium protocol that actually I stole from MD Anderson because we are trying to start a PERT team at our hospital. And if you notice, they have divided the intermediate risk group into low and high categories. So there's actually 4 categories now. And how they divide it is the high group has evidence of both biochemical right heart dysfunction and on imaging, whereas the low intermediate group, it's either or. So the biggest question to ask here is, With the intermediate risk group, there's a 5 to 15% 30-day mortality, which if you look on the other end of that, that means that the majority of patients are going to survive 30 days. And the biggest question is how do we identify the subset of patients that will require an intervention in order to survive? And right now, that answer on this algorithm is going to depend on the PESI score. So in the intermediate risk group, there's a PESI score cutoff of 86. And if you have an 86, that puts you in a high intermediate group with a high PESI score. And if that's the case, then the algorithm does recommend some sort of catheter-directed intervention. If you're in the high score, but your PESI score is less than 86, the recommendation is for anticoagulation. Let's get to a few case studies. This is a 20-year-old, previously healthy 20-year-old senior airman who showed up in the hospital with 24 hours of shortness of breath. Her only risk factor was oral contraceptive use. She was evaluated biochemically, had mildly elevated troponin and BNP. On echo, she had mild right heart strain. And according to the algorithm, she is a high intermediate class, but low PESI score. So essentially, we should be able to treat her just with anticoagulation. However, we decided to treat her. And the reason being is that in the military, we have one more classification that is required of us, and we have to get our patients, and that's the idea of readiness. And that is basically how quickly can I get my patient back to normal and back to work. So we decided to treat her. In choosing a treatment for her, we decided to treat her with an ECOS catheter. This is a catheter that you insert into the pulmonary artery all the way through the clot, and it delivers TPA directly to the clot and uses ultrasound assistance to increase clot penetration of the drug. With the newer recommended infusion times, it's very short. It's only about 2 to 6 hours, so the patient actually gets very little drug in total, and it's been a very safe and effective procedure. So here we laid 2 catheters in each one of her pulmonary arteries. We also placed an old, Swan-Ganz catheter and measured her PA pressures. Initially, they were 35/10. Here's our initial pulmonary angiogram. We brought her back the next day after we went a little long. We probably went 12 to 14 hours of TPA. And her initial PA pressures were 25/8 after that. And here is her completion pulmonary angiogram, which showed basically filling out to the periphery of the lung. In our next patient, we have a 60-year-old male VA patient with comorbidities, CHF, hypertension, and he presented with acute shortness of breath, was tachycardic, hypoxemic, required 2 liters of oxygen. His D-dimers were elevated. He had elevated troponin and BNP. He had a saddle embolus on CTA and had bilateral DVT in his FEMPOP. So this patient was high intermediate risk with a high PESI score, actually about 100. We decided to treat him with a penumbra device. This is a mechanical aspiration system with a microprocessor that gives you audiovisual cues to help you identify the clot. There's also a little, it's 12 French in size, and there's a little separator wire that you can use to help you break up and retrieve the clot. Here's the initial pulmonary angiogram. You can see the right lower lobe has a significant burden of embolic, and we cleaned that out. And then the upper lobe also for a final PA pressure of 35/20. This is a 66-year-old patient who actually came in and said that he had been short of breath for a month. And it kind of gotten worse over the last week, and he couldn't walk without nearly fainting. We evaluated him again with all the risk factors for right ventricular dysfunction. His category was also high intermediate risk with a PESI score of 96. He did not have DVTs. Now, for him, With his 1-month history of progressive symptoms, we were concerned that his clot had matured a little bit. And we know that over time, the clot becomes lytic resistant and it changes its morphology. It actually becomes very kind of firm and hard and rubbery and a lot more difficult to remove. So our choice for him was the FlowTriever. FlowTriever from Inari is a very large mechanical aspiration catheter. It's actually 24 French. Very large bore for large clot hauls. And the access site that we use for this is the common femoral vein. And you can treat as you go. In other words, so if you encounter iliocaval DVT, you can clear it out before you attempt to treat the PE. If you encounter a clot in transit, which is essentially a DVT that's somewhere between where it originated and the PE, and if it's hanging out in the right heart, you can also clear that as well. It's a single session, there's no lytics, and the biggest advantage is that you can return the majority of the blood to the patient. There's a full range of catheters and tools that you can use to help do this. His initial PA pressures were 66/17, so the echo was right. Here we cleaned out the right lung on completion, and then on the left side here's our completion as well. This patient did very well postoperatively, was literally discharged home the next day. So for this case, this is another 66-year-old with a high intermediate PE with an elevated PESI score. He had a large amount of left-sided clot, and he was hypoxemic as well. And I'd like to pay attention to our procedural notes here. We did 10 aspirations with a 24 French catheter. We did not use any thrombolytics. Our total estimated blood loss for this case was about 20 milliliters. We returned about 600 milliliters of blood back to the patient. Post-procedure, he started out the procedure on 5 liters of oxygen, and post-procedure, we were able to take the oxygen off and felt a whole lot better. Yeah, you can see the very large burden of clot in the left PA. Here it is here, and you can see the different color variation of the clot, meaning there's different stages there. There's acute clot, there's subacute clot, there might be some chronic clot in there, and this tool is able to do that. For this last picture here, as I said, with this device, you can treat as you go. This was a case that one of my colleagues did, and there was a large clot in transit, and aspirated this from the right atrium. And that's the clot you see on the bottom, and you can see it's pretty much the shape of an iliocaval vein with the bifurcations and everything involved. And if that clot had gotten to the lungs, it would be a very different story for this patient. So you can really significantly decrease this patient's mortality risk. So in summary, acute PE is the 3rd leading cause of cardiovascular mortality, and I think one of the most preventable. Risk stratification is very important for these patients, and we may need to consider other things like the presence of DVT and the ability to treat that at the same time. The PERT team is an incredibly valuable resource and tool that can drive effective inpatient care. And then choosing the right tool for the patient, I think, is also as important. And then also to follow these patients up in clinics and their subspecialties is a huge importance as well. Thank you very much.
Thank you, Frank. That was awesome. Is there any questions for Dr. Cuozzo or for Katherine? We're moving well on time, but happy to take any questions now. Aaron?
What's your site when you do the venous procedures? Are you going into the iliac vein?
We're going through the common femoral vein. And 24 French common femoral vein, 24 French is a pretty large hole to put in so in order to close that, we actually use a little, what's called a bolstered suture, where we suture the skin with a bolster and we hold compression. And the post-op complications from bleeding are nothing. They do very well. We usually take the bolster out in 24 hours and they go home. Correct. Right atrium, right ventricle into the main pulmonary artery.
You know, Dr. Cuozzo says about a 24 French sheath. I want you to put out your thumb. That's how big the sheath is. That's how big the catheter is. It's not little, but very effective. Awesome cases.